Hello, everyone. I'm Hyunjun Kim. I'm Research Assistant Professor at University of Washington School of Social Work and Director of Health, Sexuality, and Gender Research Unit of the Golden Institute. We have three speakers at this symposium, Dr. Charlie Hoyalis, Dr. Megan Romanelli, and Dr. Haley Zhang. All of us are working as a team. Dr. Hoyalis is an assistant professor at the University of Utah. His scholarship focuses on the mental health and well-being of LGBTQ people, especially midlife and older adults. He has nearly 20 years direct practice experience as a licensed clinical social worker, providing services to the LGBTQ community. Dr. Romanelli is an assistant professor at University of Washington. She's also a licensed clinical social worker with over 10 years of experience across various therapeutic settings. Her research program primarily aims to understand and address the multisystemic factors that lead to mental health disparities among LGBTQ communities, with a focus on the role of restricted service access and treatment engagement. Dr. Zhang is a research scientist at the Golden Institute, University of Washington. She earned her PhD from University of Pittsburgh School of Social Work. She has been involved in multiple research projects investigating life trajectories of disadvantaged populations. Her broad research interest is on social determinants of health and health disparity among marginalized populations, including LGBTQ older adults. The findings the presenters will discuss today are from Aging with Pride, National Health, Aging, Sexuality, and Gender Study, or NHAS, and another project, Wellness with Pride, built upon the findings from the NHAS and designed to understand experiences of LGBTQ adults during the pandemic. Let me give you a brief overview of the NHAS study before we jump into the speakers' presentations. The NHAS study was designed to fill gaps in LGBTQ aging and health research, and it started with identifying health disparities utilizing population-based data. As an example, recently we were able to pull US National Health Interview Survey data and investigate health disparities among LGBT people aged 50 and older in the US. We found that LGBT adults aged 50 and older were more likely to report potentially disabling chronic conditions, including stroke, heart attack, asthma, and arthritis. LGBT older adults were also more likely to report poor general health, mental distress, disability, cognitive impairment, sleep problems, and smoking. Sexual minority older women were also more likely to report excessive drinking. So evidence of health disparities among LGBTQ older adults has been accumulating, but further research is needed to understand what factors contribute to these health disparities so that we can make interventions and policies that would promote health equity. To this end, the NHAS is now conducting a longitudinal study with 2,450 LGBTQ older adults across the US. This longitudinal study investigates the health, aging, and well-being of LGBTQ older adults and their risk and protective factors. The baseline data were collected in 2014. The inclusion criteria were being born in 1964 or earlier, and self-identifying as LGBTQ or as someone who was engaged in same-sex sexual behavior, attraction, or romantic relationship. Participants were recruited via community-based agency contact lists across all US Census divisions and social network cluster chain referral, stratifying by cohort, gender, race, ethnicity, and geographic location. Paper and online surveys were completed according to each participant's preference. We are collecting follow-up data every other year. The NHAS is guided by the health equity promotion model. Much of the sexual minority research has been driven by stress-related models focusing on mental health problems. What we see from our previous studies is that many LGBTQ older adults show resilience despite marginalization. It would be equally important to identify health-promoting factors as well as risk factors to understand the full spectrum of health from poor health to good health. This diagram shows key explanatory factors we are investigating. In terms of the historical factors, many LGBT older adults came of age when LGBTQ identities were severely stigmatized and criminalized. Health and quality of life of LGBTQ individuals would be influenced by such historical factors. In terms of psychological, social, behavioral, and biological processes, we are talking about both health promoting and risk factors. For example, identity affirmation and identity stigma, support networks and social isolation, physical activities and substance use, and also physiological responses to stressors. The model highlights diversity within LGBTQ older adults in terms of their social positions, including race, ethnicity, gender, sexual orientation, gender identity, socioeconomic status, etc. And we are investigating this model from the life course developmental perspective, highlighting longitudinal effects of life events and also resilience in their health trajectories. I hope you find this symposium helpful to understand distinct needs as well as strength of LGBTQ adults that could be addressed in interventions and policies to eliminate health disparities and promote health equity. If you'd like to learn more about the study, please visit the website shown on the slide. The slide also shows our contact information. Please feel free to reach us if you have any questions about the study. Thank you. Now, Dr. Hoy Ellis will give a talk.
Our focus is on understanding how health disparities among today's midlife and older lesbians and gay men are consequential to historic and ongoing marginalization. To do this, we will describe how iridescent life course theory can help us contextualize ways in which historic social contexts influence key life events and experiences across the life course, which result in health disparities among midlife and older lesbians and gay men today. While our focus today is on lesbians and gay men, the iridescent life course is also applicable across the rainbow of diverse sexual and gender minority older adults. We'll be wrapping up with a discussion of the implications of the iridescent life course theory to younger generations of diverse sexual and gender minorities. More than a decade of research has firmly established that compared to their heterosexual age peers, midlife and older lesbians and gay men experience significantly higher rates of mood, anxiety, and substance use disorders, suicidality, and chronic health conditions, such as cardiovascular disease, hypertension, obesity, and asthma, among others. The science of social determinants of health, that is, the causes of health disparities, goes back to the Whitehall studies of the British civil servants nearly 40 years ago. It is important to understand that lesbian and gay health disparities are the result of social marginalization and nothing inherent to being lesbian or gay. Yet researchers rarely include sociocultural historical context as social determinants of health in research designs. The iridescent life course extends existing work in the following in several ways. It incorporates the intersectionality of sexuality and gender, as well as other social positions, and considers how these positions interact to shape opportunities and constraints. It addresses the fluidity inherent across identities, as well as the ways they interact with each other to reflect aging lives as they shift over time. It highlights the consequences of divergent representations and viewpoints of and about disadvantaged older adults and their interactions with individual, interpersonal, social, and structural opportunities and barriers. Furthermore, it illuminates the social construction and power dynamics inherent in the lived lives of marginalized older adults, such as through queering and transforming of the life course, which sheds light on heterosexual and gender normative nature of most existing gerontological research. It also elucidates psychological, behavioral, and biological factors that influence the lives of older adults, along with critical social factors. Although there is increasingly more research on the health and well-being of sexual and gender minorities, there has generally been a lack of attention to similarities and differences between distinct generations and the historical influences that might account for such differences. In this study, we wanted to better understand the life events and experiences of different generations, including the invisible generation, born between 1920 and 1934, the silenced, born 1935 to 1949, and the pride generation, born 1950 to 1964. We examined demographic characteristics, key life events and experiences, those related to identity, kin relations, work, traumatic experiences, and community engagement within historical and sociocultural contexts, potentially influencing current health indicators, such as physical impairment, HIV/AIDS, depression, quality of life, along with potential interactions between generations and gender. For this study, we analyzed a subsample of 338 lesbians and 1,241 gay men from the 2014 wave of the National Longitudinal Aging with Pride National Health, Aging, and Sexuality Gender Study that we affectionately refer to as NHAS. We recruited for the survey arm via 17 community partners across the nation, representing all 9 US census districts that serve sexual and gender minority older adults. We applied survey weights for descriptive statistics of socio-demographic variables and 2-step post-survey adjustments, comparing generation and gender, and compared life events and experiences by generations through linear and logistic regressions to examine interaction terms by generation. Participant mean age was about 61.5 years. About 1 in 5 were people of color. Just under 3% identified as transgender, gender diverse, or non-binary. 26% had high school or less education. About a third had incomes equal to or less than 200% of the federal poverty level, and just over 43% lived alone. One of our identity variables is age of disclosure was a single question asking for age and years when participants first disclosed their sexual or gender identities. For work, we asked whether or not participants are currently retired, and separately whether or not they had ever served in the military. Lifetime victimization is one of our variables based on biased experiences, with some scores to frequencies of experiencing 9 types of victimization. For example, verbal and physical threats, verbal, physical, and sexual assaults during the lifetime as a result of their sexual orientation or gender identity or expression. Frequencies range from 0 equals never to 3 equals 3 or more times. Physical impairment is the mean scores of 8 items assessing physical functioning, defined as difficulty with lower and upper extremity performance. Items include walking a quarter of a mile or standing on your feet for about 2 hours or sitting for about 2 hours, with a possible range of 0 equals no difficulty to 4 equals extremely difficult or cannot do. Health and well-being measures included whether or not participants had ever been diagnosed with either HIV or AIDS or both. Depression is a dichotomized variable of clinical significance based on some scores of 10 items for the Center for Epidemiological Studies Depression Scale short form, also known as the CESD-10. The scale asks participants to indicate how often they have felt or behaved in the last week in certain ways. 0 equals less than 1 day to 3 equals 5 to 7 days. A score of 10 or greater is indicative of depression. We used the World Health Organization Quality of Life Brief, which is a single item that asks participants, how would you rate your quality of life? With responses ranging from 1 equals very poor to 5 equals very good. Due to time constraints, we're only able to provide a few brief highlights. As you can see here, the oldest group disclosed their identity on average at older ages and were more likely to be retired, to have served in the military, and to have survived the death of a partner or a spouse. The youngest group was significantly more likely to have disclosed their identities at younger ages and experienced higher levels of victimization and discrimination compared to both the oldest and the middle groups, with important gender and generational interactions. The invisible generation had higher physical impairment than the pride generation. while the Pride generation had higher rates of HIV/AIDS, depression, and lower quality of life. These two tables highlight a couple of our findings when we ran gender by generational interaction terms. Gay men had higher rates of victimization than lesbians in the Pride and the Silence generations, but there was no gender difference in the Invisible generation. Gay men from the Invisible generation were less engaged in the LGBT community than lesbians as compared with the Pride and the Silence generation. In other words, the level of community engagement was higher among lesbians from the Invisible generation compared to their gay male counterparts. The study is among the first to analyze health, kin, social, and intrapersonal data across generations of lesbian and gay men, and to do so using iridescent life course theory. Yet we need to pay more attention to the intersectionality of demographic characteristics and the life course. It will also be important to keep a focus on gender and racial differences and how historical times may unfold differently for all genders. Tragically, yet ironically, we are in the midst of a major rupture that will be a defining point for generations to come. The world as we knew it just a brief 2 years ago has been disrupted in unimaginable ways by COVID-19. Historical generations theory postulates that cataclysmic historical events are the catalysts for new generations, as opposed to the more traditional, objective, repeating, age-based, regular temporal cycles. And when historical events reach deeply into society's institutions, they have a profound effect, especially on younger people. Also important is recognizing the depth of contributions that LGBT people, communities, and cultures have contributed to reshaping and recreating society as a whole for the better. Moving forward, we have the opportunity to apply this framework to younger generations of LGBT people to see how the iridescent life course will unfold as realities of intersectionality and queer identities take their place in the current context and in future generations. That's my part of this presentation. I want to thank you all again for showing up to learn about the iridescent life course theory and how it helps us better understand health disparities among LGBT older adults, both today's and tomorrow's. If you'd like more information about this study or any of our numerous other studies, freely available publications, or our other programs, such as Aging with Pride, Project IDEA, which is an acronym for Innovations in Dementia, Empowerment, and Action, here is some contact information. Again, thank you all very much.
Hello, everyone. I'm grateful to be here with you today. I'm Megan Romanelli from the University of Washington School of Social Work and the Goldston Institute. I'm excited to present findings from the study Differences in Healthcare Needs and Access Among Transgender, Gender Diverse, and Cisgender Adults Since the Onset of COVID-19. Just as a brief overview for today's presentation, I'll start with some background related to the access needs and barriers among transgender individuals, review current research questions and methods, give an overview of key results, and discuss implications of the research. Transgender or trans individuals experience disparate rates of health concerns compared to cisgender counterparts. For example, they experience increased rates of smoking, heart disease, and some cancers, and decreased immune health, which it should be noted are all risk factors for serious COVID-19 infection. These elevated rates render access to effective health care as imperative, and this ensures access to health screenings and treatments. However, gender minorities often face significant barriers to care, or if they do reach care, they're often ill-served in healthcare environments. The COVID-19 pandemic may have only exacerbated existing barriers, which might have widened existing health disparities or created new ones due to foregone COVID-19 related healthcare. So this study examines differences in healthcare needs and barriers to care since March 2020, which is the onset of the COVID-19 pandemic, as well as COVID-19 related testing and health. And we compare outcomes of cisgender, trans, and gender diverse participants. Specifically, the study asks, since the onset of the COVID-19 pandemic in March 2020, are there significant differences by gender identity in healthcare needs, barriers to healthcare, and COVID-19 testing behaviors and health outcomes? The study utilizes data from the Wellness with Pride study, a study that expanded upon the National Health, Aging, and Sexuality Gender Study to include those 18 and older. Distribution of the online survey began in August 2020, and the study took participants around 10 to 15 minutes to complete. Each participant was offered the opportunity for entry into a random drawing for one of 12 $200 gift cards. To identify participants, the survey was advertised by email, announced to partner agencies, and through Facebook and Google Ads. Inclusion criteria were that participants identified as lesbian, gay, bisexual, transgender, non-binary, queer, or sexual or gender diverse, that they were age 18 or older, and that they lived in the US. Data collection is currently ongoing, and as of data analysis, which occurred in February 2021, there were 650 participants, including 480 cisgender respondents, 126 transgender respondents, and 404 gender diverse respondents. I'm not going to go too in depth into our measures. Most are pretty straightforward, asking if participants needed health or mental health services, yes or no. If they had difficulty locating services since the start of the pandemic, yes or no. If they had a checkup in the past 12 months, yes or no. If they had health coverage, a healthcare provider, or needed but couldn't get healthcare since March 2020, yes or no. Next, we ask specific questions or reasons for delaying or foregoing care. If they couldn't afford it, couldn't get an appointment, the doctor canceled or closed, they decided it could wait, they were afraid to go, or another reason, for example. Finally, we ask questions specific to COVID-19, if the participants had ever been tested, yes or no, or if they had COVID-19, yes, probably yes, no, probably no, or they weren't sure. Analyses were conducted in STATA 16. Frequencies and percentages were calculated, and differences in service need, healthcare access, and COVID-19 outcomes across gender identity were compared using chi-square tests. As a brief overview of background characteristics, results showed that trans and gender diverse respondents were significantly younger than cisgender respondents. Trans and gender diverse respondents had higher rates of queer identity, while cisgender respondents had higher rates of lesbian or gay identity. Cisgender respondents were majority non-Hispanic white and had higher rates of graduate degrees. We saw no differences in socioeconomic status, HIV status, and also partnership status. So moving on to our main research questions, starting with service needs. Both trans and gender diverse respondents needed health and mental health services at higher rates than cisgender peers. So going back to look at those differences in reported need for health services, we see that around 57% of transgender and 55% of gender diverse respondents needed these services, compared to only 42% of cisgender respondents. And we see these numbers highlighted in yellow on the screen. With mental health services, again, we see higher reported need among trans and gender diverse respondents. About 68% of trans participants and 66% of gender diverse participants reported needing mental health services, compared to only 39% of cisgender respondents. Despite high need among trans and gender diverse participants, they also reported greater difficulty locating services since the start of the pandemic. So here we see higher rates of this reported difficulty, with 72% of trans participants and 71% of gender diverse participants having trouble locating services since March 2020, compared to only half of cisgender participants. So along with difficulty locating services since March 2020, trans and gender diverse participants had higher rates of generally experiencing a healthcare barrier compared to cisgender participants. So here we see that trans and gender diverse respondents reported barriers at approximately 81 and 77%, compared to cisgender participants at approximately 64%. When asked about specific barriers to care, a few significant differences emerged around service affordability, deciding that care could wait, and being afraid to go to the doctor. So here we see trans and gender diverse participants reported affordability as a specific reason for delaying or not getting care at rates of 25% and 23% respectively, compared to only 14% among cisgender respondents. Deciding care could wait as another reason for delaying care was significantly different among cisgender, trans, and gender diverse respondents. So here we see close to 39% of trans and 36% of gender diverse participants cited this reason, compared to only a quarter of cisgender participants. And finally, related to barriers, trans and gender diverse participants indicated being afraid to go to the doctor at higher rates than cisgender participants. So we see elevated rates again among these groups at 38% and 32% compared to only 24% among cisgender participants. And when finally, when it came to COVID-19 related outcomes, we see cisgender respondents having significantly higher rates of certainty. For example, definitively saying that they had not contracted COVID-19. We see here that cisgender participants reported this at close to 69%, while trans and gender diverse participants reported certain negative tests at 51% and 57%. Alternatively, we see significantly higher rates of uncertainty among trans and gender diverse participants when it comes to their COVID-19 related status. So they report that they probably yes or probably no contracted COVID-19 at significantly higher rates than cis respondents. So here we see that trans respondents reported that they probably yes contracted COVID-19 at rates of 10.3%, while cisgender participants only reported this at 4.4%. And trans participants reported that they probably did not contract COVID-19 at rates of 32%, and gender diverse respondents at rates of 30%, while cisgender respondents only reported this level of uncertainty at 20%. And so we'll talk about how those previous healthcare access factors may impact these levels of uncertainty. But first, findings show that although trans and gender diverse participants needed health and mental health care at higher rates, they generally reported experiencing more barriers to care since the onset of the COVID-19 pandemic. And these barriers to care result in widening health disparities, many of which the CDC have identified as associated with serious COVID-19 illness. And we think it's important that interventions target the most salient barriers identified by trans and gender diverse respondents. They had difficulty locating services, affording services, decided care could wait, and were afraid to go. Intervention should target improving service outreach and visibility, cost, enhancing care seekers' attitudes towards service relevancy and urgency, and improving service environments to decrease failure. These interventions need to be implemented to increase access for trans and gender diverse respondents generally, but especially within the COVID-19 context, because of participants, they were significantly more likely to be uncertain about their status. And this might point to testing barriers. So even though we found no difference between the report of ever being tested, participants may not have been tested every single time that they experience a potential exposure. And to improve barriers to care and also service acceptability, it's important that trusted community partners and organizations like LGBTQ organizations and health centers lead the outreach and education around COVID-19. It's also imperative that increased testing and vaccines are made available to LGBT-specific health sites. So with that, I'll end. And to find more information for Wellness with Pride, our contact information can be found on the slide here. Thank you all for being here, and I look forward to your questions.
Hi, my name is Haley Zhang, a research scientist of the Golson Institute at the University of Washington, Seattle, United States. The title of this presentation is Patterns and Predictors of Health Behaviors Among Sexual and Gender Minority Midlife and Older Adults. In this session, I present 4 distinct latent classes associated with health behaviors and behavior-related healthcare barriers among LGBTQ adults aged 50 and older in the US. LGBTQ older adults hereafter. Some declarations on funding, no conflict of interest, and approval on human subject research. Health behaviors are a strong predictor of health and well-being among older adults, and promoting healthy behaviors like exercise and preventive care are a key to preventing chronic conditions. However, LGBTQ older adults are at higher risks of health risk behaviors like substance use and lack of physical activity. Importantly, health behavior risks are associated with constraints like barriers to healthcare access. Given that health behaviors are modifiable in healthcare interventions, understanding health behaviors in conjunction with healthcare barriers is an important step. Previous studies documented how different types of health behaviors and healthcare access barriers correspond to health outcomes in later life. However, these studies primarily focused on independent role of each indicator, and the conjoined patterns have not been examined. In fact, health risk and health promoting behaviors coexist and both affect health outcomes. Different behaviors occur simultaneously within an individual, and they influence each other. The lacking focus of analysis on the patterns and clusters warrants such investigations because understanding the complex patterns would enable more targeted and effective intervention towards health equity. Individual behaviors interact with ecological systems, which is highlighted by social determinants of health. The lack of socioeconomic and environmental and other resources discouraging healthcare access, like distrust or low health literacy, affects health behaviors. Therefore, investigating healthcare barriers along with barrier behaviors is very important. We draw on the health equity promotion model that comprehensively considers multidimensional factors and processes over the life course of LGBTQ older adults. According to the model, health behaviors and barriers are influenced by diverse environmental, psychological, and social experiences and affect health and well-being. For example, a previous study drawn from this model showed health risk and health promoting behaviors were significantly predicted by marginalization experiences and in turn directly associated with their physical health. There are three aims of this study. First, to identify latent patterns of health behaviors and healthcare barriers among LGBTQ older adults. As shown in green, we used 14 measured variables, including 3 health risk, 3 health promoting, 2 preventive care use, and 6 healthcare barrier indicators. Second, as shown in dark blue, we examined differences in health-related quality of life, or HRQOL, depending on these latent classes. 3, as shown in light blue, we explore predictors of the class memberships. Predictors are drawn from the HEPM, focusing on social positions, marginalization experiences, and psychological and social factors. Covariates are disability and depressive symptomatology, given their association with capacity to engage in certain behaviors. Using MPLES and the baseline data of the US National Health, Aging, and Sexuality Study, we performed 3-step latent class analysis with survey weights. Latent classes of health behaviors and barriers were generated and fixed, and using these classifications, mean differences in HRQOL across the classes and the predictors of the class membership were examined. Shown are the binary measures for latent class generation: smoking, excessive drinking, and drug use for health risk behaviors, physical activity, sufficient food intake, optimal sleep hours for health promoting behaviors, regular checkup and flu vaccination for preventive care use, financial barrier, distrust in healthcare, unavailability of LGBTQ friendly services, low health literacy, postponement of care, unwillingness to receive care for healthcare barriers. Other measures include social positions measure, age, income, education, race, ethnicity, gender and sexual identity, and relationship status, For covariate disability and depressive symptomatology, both dichotomous. For biased experiences, lifetime discrimination and victimization as a summed frequency, day-to-day discrimination as a mean of 6-item scale. For psychological factors, LGBTQ identity stigma was a mean of 8-item scale. Mastery was a mean of 4-item scale as social support and LGBTQ community engagement were. Both HRQL dimensions were summary scores of the WHO Quality of Life Scale. More information and descriptive statistics are available upon request. So the findings. Comparing 1 to 6-class LCA model, 4-class model had the best fit. Table shows BIC is the lowest with 4 classes versus AIC with 6 classes. AIC tends to overestimate models with more classes. LMR likelihood ratio test suggests 2 classes are preferable to 3 classes model and no improvement from then on. Regarding interpretability, 2 classes were too simplistic. Although the 4-class entropy is less optimal, the average posterior probabilities indicated good class separation. Y-axis is conditional probabilities for the 14 indicators shown on the x-axis. The largest class, 39%, is class 1 in orange and named healthy behaviors and minimal barriers. It has average likelihood of health risk, high probabilities of health promoting and preventive care behaviors, and minimal barriers. Class 2 in yellow, less healthy behaviors and high barriers makes up 31%, shows slightly higher than average health risk, lower than average health promoting and preventive care behaviors, and high probabilities of barriers. Class 3 in green, healthy behaviors and healthcare system barriers is 19% and similar to class 1, except that they have higher probabilities of healthcare system barriers like unavailability of services, distrust, and lower health literacy. The least prevalent class, 11%, was class 4, optimal health behaviors with risks of limited healthcare access, showing minimal risk behaviors and very high health promoting behaviors, but the lowest preventive care use and overall moderate healthcare barriers. Regarding mean differences in HRQOL, class 1 orange had significantly higher physical and psychological HRQOL than class 2 yellow, and higher physical HRQOL than class 3 green. However, no differences were found between class 1 and class 4 brown, optimal health behaviors with risks of limited healthcare access. In comparing yellow class 2 and green class 3, class 2 had lower psychological HRQOL than class 3. Table presents the multinomial regression findings that predict class membership. Class 1, healthy behaviors and minimal barriers is the reference. Several factors predicted class 2 membership as compared with class 1, but classes 3 and 4 were not very different from class 1 in predictors. First, for social positions and covariates, younger age, higher education, people of color, self-identifying as women, disability, and depressive symptomatology was associated with higher odds for class 2 membership. Class 2 is the unhealthy behaviors and high barriers group. The odds for class 2 membership increased with higher discrimination and lower mastery and social support. Summing up, this is the first study identifying heterogeneous clusters of LGBTQ older adults for health behaviors and healthcare barriers. To note from the findings is that the healthiest people with protected behaviors and minimal barriers make up 39%, the largest portion. Class 1 represent a desirable pattern of behaviors and preventive care use while showing average level of health risk behaviors. Healthcare barrier was also low. They are a resilient group and exemplify the importance of highlighting resources and strength beyond challenges and risks. Their physical and psychological HRQL levels were higher than other clusters. Next is class 3, 19%, has overall similarity to class 1. The prominent differences lie in healthcare system barriers, such as unavailability of LGBTQ-friendly services, distrust in healthcare, and low health literacy. Despite some elevated barriers, their rates of preventive care use are higher than the other classes. The higher likelihood of experiencing service unavailability is associated with cultural incompetency of healthcare, and low health literacy and distrust in healthcare are major obstacles to health communication and access. Importantly, these elevated barriers were associated with lowering of physical HRQOL. They have financial resources and are using preventive care at high rates and show health promoting behaviors, but their physical HRQOL is still lower than class 1, implying their preventive care use may not capture quality of care and not lead to getting additional needed care because of their perceived barriers. Improvement in quality health care for LGBTQ individuals is needed given discrimination and insensitive treatment commonly experienced, which is significantly associated with distrust in the care system. Class 4 is the least prevalent, 11%, and unique. Their health promoting behaviors are outstanding with almost non-existent risk behaviors. Surprisingly, however, preventive care use is the lowest and healthcare barriers are substantial, particularly high in care postponement and unwillingness to receive care. Nonetheless, their HRQOLs are relatively high, comparable with class 1, the healthiest. They appear to be a small subgroup who don't yet have significant health issues and can maintain health without receiving much health care, only with self-initiating health-promoting behaviors or refrainment from risk behaviors. Maybe compensating distance from healthcare system with their proactive behaviors, which seems effective so far. However, we do not yet know if other more objective measurement of health would still support this, nor this would continue as they age. Expanded research, including other health outcomes and their trajectories, is needed. Lastly, class 2 may be called at-risk group. They show higher than average risk behaviors, lowest health promoting behaviors, low preventive care use, and highest healthcare barriers. More than 3 out of 10 belong to this class. Their physical HRQOL were significantly lower than classes 1 and 4, and their psychological HRQOL was lower than all the other 3 classes. Class 2 membership was associated with younger age, people of color, women, disability, and depressive symptomatology. Women more likely in class 2 is consistent with previous knowledge that LGBTQ older women than men have broader health disparities compared with heterosexual cisgender counterparts. Also, consistent with previous studies, membership in this at-risk class was associated with more discrimination and lower social support and mastery. It suggested that these modifiable predictors can be used to reduce the gender gap. Interventions to boost their mastery and strengthen social support are needed to help them unite and build strong community, resist marginalization, and educate others. Importantly, people of color are more likely to belong to the at-risk classes than non-Hispanic whites. It may reflect their cumulative disadvantages. Research and practice efforts on the intersectionality of race, ethnicity, and sexual gender identity should continue for the best possible trajectories of equitable health. A few limitations. We used a cross-sectional data, and the findings do not imply causality, and future longitudinal studies will be able to test causality and clarify trajectories of each class. Limitations inherent in self-reports applies to this study, including imperfect memory. Research with other important indicators is needed, including healthcare coverage, wellness activity, barriers to social services, and relationship with provider. Despite the limitation, this study lays an important ground for future research. Although 6 out of 10 were found to have healthy behaviors, other potentially influencing variables will help better understand modifiable factors and pathways for at-risk population. Also, Efforts to mitigate healthcare system barriers are critical since system barriers are directly associated with low use of preventive care, compromised quality of care, and adverse health outcomes. References are available upon request, and thank you.
Thank you, Dr. Hoyalis, Dr. Romanelli, and Dr. Zhang for your presentations. And thank you for your attention, everyone. And now we have a few minutes to answer your questions. Hi, everyone. Thanks again for your attendance. We have about 15 minutes for Q&A. So please feel free to ask us questions. And yeah, we'll be happy to answer. So probably, yeah, so we don't have any questions so far. So probably we can start with some kind of, if you can share, Megan, Charlie, Haley, if you can share some kind of, what could be kind of next steps, and in terms of research implication and policy, intervention implications, things like that.
So I think I can start when we were just having a short, brief discussion when a few things came up. The first is thinking about my study, which included those 18 and older. And one thing to think about was that these disparities are occurring with those 18 and older, and to think about how age might only exacerbate these disparities and health disparities and access disparities. The second thing to think about was that in my study was a pretty simple analysis looking at individual behaviors and individual health access outcomes, and how in my study I found these gender disparities. But when comparing that to Haley's study, she was looking at more comprehensive and complex clusters of behaviors and how there were no gender disparities in that. So to look forward in research is to kind of think about how behaviors don't happen in isolation, and to think about these complex behaviors happening simultaneously. So I might pass that off to Haley to speak more about how these behaviors might cluster together and how we should look at that.
Yeah, so as my study kind of started to shed light on the behaviors and barriers and their complex relationships among those, so certain behaviors like health risk behaviors occur together, but those people with presenting certain risk behaviors also have health promoting behaviors, and also they could actively participate in preventive care use. And they have different characteristics of health barriers and healthcare access. So I think and find it is really important to think collectively and comprehensively all the possible factors as much as possible. So as I said in the presentation as well, there are variables that I couldn't include, including health insurance and primary care physician and other factors as well. All different kinds of screening healthcare access variables too. So if data allows, if we could include those variables comprehensively, that would illuminate more clear picture of the behaviors and barrier and their relationships. So, yeah.
Mm-hmm. Thanks, Haley. And I think that to continue along the line of thinking that y'all are presenting. So we certainly know that individual behaviors matter. We know that we need to look more comprehensively across domains as opposed to just focusing on particular domains.
But, as the iridescent life course theory points out, it's also critically important to consider historical and sociocultural context and how that becomes embedded and how that is carried across the life course. So, for example, a lot of our research has shown that the particular stressors that were prominent for today's LGBT older adults, say in the 1950s during the McCarthy era, that shaped experience in one particular way, and also because of the age that you were. So today's younger people are experiencing COVID, and so when those ruptures with the past, and when there are cataclysmic events, and I think I'd be pretty safe in saying that COVID has been a cataclysmic event, and has really gone deep into the institutions of society. And so what younger LGBTQ people are experiencing today is, our research strongly suggests, is going to not only showing up, so like you said earlier, Megan, that we're seeing health disparities at younger ages, but going forward, because there are ways that history and sociocultural forces are the same, but they're also unique. And so I think it's important to recognize that what younger LGBT people are experiencing today is going to be showing up in their psychological, physical, biological, social, cultural lives pretty much for the rest of their lives.
Yeah, so I think that our study, the N has the strength of this study is we're collecting data over time, and definitely I think we'll be able to test more kind of these changes in healthcare access and also health behaviors and also the health outcomes all together, and see how they are intertwined, interplay, how they interplay. And and I think empirically further kind of test the HPM. So that's I think the next step for the NHAS study. Looks like we have a question, and for Goodman, Gloria, I came to the symposium late. What was the N for your 3 groups? Question is for Charlie.
The N for the 3 groups was so we had 2014 wave of the NHAS. There were 838 lesbians aged 50 and older and 1,241 gay men aged 50 and older. About a fifth of those collectively were Black, Indigenous, other people of color. Little under 3% were gender diverse, non-binary, transgender. Just over 1 in 4 had a high school education or less. And right at about a third are living at or below 200% of the federal poverty level. And 43% are currently living alone.
Yeah. So the N for each generation was Charlie. Do you have that?
Let me see here.
The overall N was about a little bit over 2,000 for this paper, right?
Correct. And
the price, yeah.
The N for each generation was
I found that here. If you don't mind, I can jump in, Charlie.
No, that's great.
So the N for pride generation is 894, silence generation 1011, invisible generation 174. So there was our N for so invisible generation has smaller sample size than other generations, but still it has big enough to do kind of meaningful analysis. Okay, we have another question. Who is the seminal author on the iridescent life course theory? I'd like to familiarize myself on a deeper level with this theoretical framework.
Well, I would say Dr. Karen Fredrickson Goldson is probably kind of leading the rest of us in developing this.
Mm-hmm. Right. So we are working on this paper is actually under review right now. I think it's close to kind of publication, right? So we'll be happy to send you this paper once it's published. And you can go to the goldsteninstitute.org. We have a publication page. We update that publication page regularly, so you will be able to find that paper from there. Okay, so no one has, if no one has any further questions, I think we can kind of wrap this up. I have an announcement to make. Our team has another symposium on the 16th from 2:30 p.m. to 3:30 p.m. Argentina time, and speakers will discuss findings from Global Pride study. We collected data from 18 countries. So yeah, and also, if you have any further questions, please feel free to reach out to us at agepride@uw.edu. And thanks again for your participation, and enjoy the rest of the conference. Thank you.